All right, thank you all for being here. We're really excited to have so many different professions and disciplines represented here today. That was really what we were aiming to do today, is reach across so many different disciplines and bring different perspectives to the table. And we hope that there's a nice flow today in terms of our presentations to begin to answer some of your behaviors as it relates to dealing with difficult behaviors in whatever line of service or within your own family as they emerge. So to start out today, we're really going to be focusing on talking about screening and understanding behavioral issues and service delivery. We've used service delivery as kind of this broad spectrum term, meaning that it could be within an educational setting, it could be within any different type of modality of service delivery. So again, looking forward to that. So again, I'm Jason Gent, because I think we were hiding up front, and this is Dr. Hirschhorn. Loved working with this guy for a long, long time. Here are our disclosure statements. I'm going through mine right there. You can read it. I won't bore you with it. And there is Dr. Hirschhorn's. All right. And again, our main objective of our presentation is really talking about identifying strategies to screen for behavioral issues in service delivery settings. So it's early on in the conference. I'm going to make you actually participate right away. How can children's behavior impact service delivery or teaching? So just yell it out to me, nice and loud. Wake up your neighbor that maybe isn't awake yet. How can those behaviors get in the way of what you're trying to do? Not being able to complete what you're trying to do. All right, what else? Say it again. Distraction, okay. For maybe the provider or for the child. All right, what else? I'm totally cool with awkward silence. I'm a psychologist. I can do this all day long. It could delay the intervention or the effectiveness of the intervention that you're trying to provide, okay. Anything else? Frustration. Frustration for the child or for the parent or for the provider. It could be that point in your schedule for the week you're like, ooh, I am not looking forward to this appointment. Or for the parent too, of like, we're trying to accomplish this and I feel like we're not getting anywhere. All right, so I threw a bunch of these in there. So for the kid, there could be some low frustration tolerance for perceived difficult tasks, difficulties due to distraction. A child could be refusing to engage in the task that you need them to be doing. Someone hit on the attention. Failure to complete those tasks, so we had that one as well. We could have people trying to avoid actually participating in the task. It impacts children's learning, their behavior, right? And how we teach new things to them that support the learning of others. So if you're within a classroom and you have a child with lots of behavioral problems and they're disrupting the class, that could impact the other people within the class. It also impacts your ability to provide that service within whatever defined setting that you're trying to do that. And if a child has difficult behaviors and you need the parents to be practicing new skills outside of that, it may make it difficult for the parents to do that as well. All right, and here's Dr. Hirsch.
So my personal welcome to everybody. We're really happy to have you all here. If you look at the prevalence of these kinds of behavioral disorders and emotional disorders in children, they're more common than you might think. About 10% of children meet criteria for a serious emotional disturbance. These obviously can have serious impacts on child's functioning and mental health. Up to a quarter of school-age criteria will meet, school-age children will meet criteria at some point in time for a disruptive behavioral disorder. And a lot of these go on unidentified for a long time, meaning that things get worse and impacts the child and the parent's life and your ability to function within within the goals you're trying to set. And we know that identifying these kids happens less often if you don't use specific tools. If you look at some of the things that you all are involved with trying to accomplish your goals, you can see that kids who have intellectual disabilities can end up with lots of these comorbidities from ADHD, mood disorders, anxiety, autism spectrum disorders, self-injurious behaviors. Kids with communication disorders often have disruptive behaviors, ADHD, poor social skills. Those with ASD, again, have a lot of these same comorbidities. Kids with developmental delays often have disruptive behaviors. Kids with feeding problems have disruptive behaviors. Hearing problems, similar. So in all of your disciplines, you're going to see kids that have these kinds of issues. And what happens if they're ignored? What happens if we don't deal with them? Well, they can proceed on to more serious complications, conduct disorder, depression, serious academic and learning disabilities, problems with peers and social environments, juvenile delinquency, child maltreatment. You can see how these children with serious disruptive behaviors can get on anybody's nerves, including their parents. So child maltreatment is an issue. Substance abuse is more common in these kids, criminal activity. And again, as we try to treat these kids, they're much less adherent to the medical regimen that we're trying to get through.
So we're not going to have a long controversy over the dress today. You probably all saw it on social media. But when we're trying to decide if a child's behaviors are within normal limits, we have to think about whose perspective that we're considering that from, what setting, what demands are being placed on the child. While we're all looking at the same individual, oftentimes we're looking at them from a different perspective. And depending on what circumstances we're dealing with the child or working with the child, or if it is our own child, that is going to impact how we perceive them and whether or not we perceive them as having problematic behaviors or behavioral health issues. Oh, this is still, sorry. All right, so when we think about, and Dr. Hirschler was talking about, our hit rate or our positive screen rate or our identification rate goes up when we consider the use of standardized screening tools versus an interview format for asking about behaviors. So when we think about that, when we use screening tools are not perfect. What's going to happen is some of the times when we use screening tools, we're going to have something that's called a true positive. So children that actually have a behavioral difficulty are going to screen positive for that behavioral difficulty. That's our perfect circumstance. We want to see that happen. Our other perfect circumstance that we want to see is that kids that don't have behavior problems, we want them to screen negative for behavior problems. But in many instances, screening tools are going to increase the rate. If it's a good screening tool, it's going to increase the rate of false positives. So it means that they're going to screen positive for something that suggests that perhaps they have a behavioral difficulty, but in real life, they don't actually have that. We do that because we think that it's more important to be able to have that follow-up conversation with the child about, or not with the child, sometimes the child, but with the parent about that and find out if that really is the case versus the problem we have going on now where we have under-identification of these issues. And then in some instances, we have a false negative. So what it means is that a child actually does have a behavior problem, but they screen negative for that. And again, depending on the perspective of the person filling that out, that may impact that rating. So just using an interview format, pediatric providers, they're pretty good at identifying kids that don't have behavior problems. However, their ability to get those true positives for pediatricians, as an example, where they've started to move towards doing more developmental screening systematically, from an interview perspective, they only have a 54% true positive rate. So they're still missing out on quite a few people. So we think that with the use of validated screening tools, there's research that suggests that that's going to increase the rate of true and false positives. So when we think about why we should screen, we all interact with children in one way or another. And when we're thinking about that, is that just from our typical interactions and have a broad spectrum of interactions with children, is that generally speaking, there's kids that we view as clearly typical. And then there's kids that are like, compared to the other kids that I deal with, there's something very different about this child. So we would define those as being clearly atypical. But then we have some people kind of in the middle. We're not so sure, or we may not have enough information to determine whether they would be falling into that typical versus atypical range. And we also view all children's behaviors kind of existing on a continuum. So when we screen, we're likely to pick up that middle ground so that it's not clear to the eye of what's typical versus atypical and those ones that we'd be perceiving as being under-identified using just an interview format all by itself. And when we're screening, and depending on the type of screening measures that you're doing, we're viewing that as something where we're looking at people that are above or below a clinical cutoff. near a cutoff of, we're not sure, but maybe this is something that we need to keep an eye on and monitor, or people that are clearly not near the cutoff. And what we're doing is, again, screening. The purpose of screening is not to diagnose, but it's really to point us in the direction of further evaluation to determine if there is a real problem there. So that evaluation point is where we feel like we're going to get a better true positive and true negative rate at that point using more comprehensive evaluation tools. So we're moving them on for a diagnostic assessment and then determining whether or not they're eligible for services or not eligible for services. If they're near the cutoff and perhaps a child has other concerns, or on the screening tool they came near the cutoff and a parent says, well, or a teacher says, I know that they didn't screen above the cutoff, but here's some of my other concerns. At that point, you can still make that referral for an assessment, or you could continue to monitor, get additional information, refer to other agencies. Or if they're not near the cutoff and a parent still expresses concerns, again, we could monitor that to make sure that that is still the case over time. Now, Dr. Hirschhorn.
So about a decade ago, the American Academy of Pediatrics realized that pediatricians were not picking up children who had these kinds of issues as frequently as we believed they existed. And so they came out with a recommendation that formal developmental screening be performed in all children at well visits. About 30 seconds after that recommendation came out, pediatricians started saying, wait a minute, how am I going to do this? And I can anticipate you saying exactly the same thing. Hold on, I have a busy day. It takes me my whole session to do this. How in the world am I going to add this to what I have to do? And the kind of things that pediatricians were thinking about were, I got all this stuff I have to do during a visit. How am I going to add this in the short time that I have to deal with this child? It does take extra time, which I don't have. It may take away, if I find all these kids, where am I going to refer them? We don't have enough providers to take care of kids if I find them. I'm not really an expert at this. How in the world am I going to pick these kids up? I wasn't picking them up before. Now, if I find them, I don't know what to do with them. These things cost money, these screening tools. Pediatricians already, our practices are run tightly, and now you have another burden. How am I going to afford this? There's no payment for these screening tools. So pediatricians were reluctant. This has been going on for a decade. And even now, despite the recommendation that all children be screened, somewhere around 25 or 30% of pediatricians are doing formal screening. So there are barriers to this. Why does this make a difference? Well, in a pediatric office, that's where parents are going to express their concerns first, usually. That means that if we can do these screening tools, we can pick the problems up more frequently and earlier so that we can get the children to a place where we can help. Parents are often more willing to discuss mental health kinds of issues with their pediatrician than they are with other kinds of specialists. We get the increased referrals, and therefore we can get the children into treatment more often. And we know statistically that if a pediatrician refers someone to a mental health provider or someone that provides these kinds of services, that adherence to what we're asking them to do, to actually go make the appointment and show up, dramatically increases. It doubles from 40 to 83%. So getting pediatricians to do this is really important. But as I said, only 25 or 30% of pediatricians are doing it. So if I look around the room, I'm certain that every one of you has run into a kid that was referred for a particular kind of therapy by you, and all of a sudden you're recognizing these behavioral difficulties that nobody told you about. So what about screening in your environment? How do we do that? Why would we do that? We really do recommend universal screening. It's really helpful. You may pick something up that the pediatrician missed or another therapist missed. In the classroom, this is really important because the information that a teacher can give to the provider really makes a difference in where we go and the kind of interventions we can do. You can tailor your interactions more appropriately if you really know where the issues are. You can identify whether or not there is a behavior that warrants a further referral and treatment from someone who has a different specialty than you do that can deal with that particular behavior problem. Depending on who does this kind of screening, whether it's done by interview or whether it's done by a formal instrument, which Dr. Gent is going to talk about, really makes a difference on the frequency that you pick this up and the time frame. In other words, the earlier you pick these up, the better the long-term outcomes. And if you can give feedback to the parents on what you're finding and how this is impacting the problems that the parent is seeing, it's much easier for these parents to understand what's going on with their child, why they're seeing these kinds of issues, and it can really provide some comfort to the parent also that we know that there's something you can do, there's something someplace we can send these people where they can get help. So questions, in your setting, how are you going to screen? When do we do it? What about, should it be universal or selective? Should you screen everybody, or should you only screen kids that you're picking up problems as you begin your intervention? We really recommend universal screening because you may pick something up now that you wouldn't have figured out until 4 months from now if you were just waiting to see what happens. So we recommend screening everybody. What kind of information is already available to you that would help you screen? What about the costs of screening? And I know Dr. Gent's going to mention some of this. The screening tools some of them are free, some of them are not very expensive. And once you purchase them from then on, they can be copied and used easily. What expertise is needed? Really, these kind of screening tools can be handed out by your secretary, somebody at the front desk, your receptionist. The parent fills them out. They're very easy to score. The kind of screening tools we're talking about can be scored by a paraprofessional. It doesn't need your expertise. And then you can review that outcome. All of you are comfortable talking to parents. I have absolutely no doubt that you could give some of that feedback comfortably to the parent, which would help them understand what's going on and the kinds of things that need to be done to help. And then you can help, again, link that parent to a treatment protocol or a further assessment for a diagnostic interview. Remember, as Dr. Gent mentioned, these are screening tools. Screening tools are designed to try to pick up everybody that's going to have a particular problem or a range of problems. They may pick up some that are normal because you're trying to catch as many as you can. So these are screening tools. It still requires a diagnostic tool later, probably not by you, but by a developmental or a behavioral specialist, a mental health provider. But these kind of things that you're doing, picking this up early, can get the parent to the provider so that we know we can really make a difference in these kids' lives.
All right, so now I'm going to run you through the gauntlet of just kind of easy peasy screening tools for you to consider. Some of these you may be familiar with. Some of them may be things you're already instituting in your agency. When just kind of trying to select some screen measures, wanted to pick things that were low cost for an agency or no cost for an agency, maybe beyond just printing costs. So we'll run through some examples relatively quickly. If you have specific questions about the various screening tools, I'm going to be hanging out most of the day, so I'll be able to answer some of those questions as well. So first up, this is broadly used in Miami-Dade County. The Children's Trust requires a lot of its providers to use the ASQ for screening purposes. Recently, actually just came out in 2015, the Ages and Stages Social Emotional Questionnaire came out. It allows for some screening of the social emotional development for a wide age range. Oftentimes when we're looking at screening tools, we see things of, infant-only screening, toddler-only screening, school-age-old screening. And this is nice because it gets us something from birth up to 72 months, and I think that part is nice, especially if you have someone that you're following longitudinally. You could be checking them over and over. Obviously, when we're talking about screening in South Florida, having things available in English and in Spanish is important. It is more difficult to find standardized screening tools in Haitian Creole, but this one is available in English and Spanish. While it gives you one broad kind of domain score, the ASQSE, it's really looking at domains in terms of like the child's ability based on their age on self-regulation, their ability to comply, how they're communicating things, adaptive functioning, how independent that they are becoming in their development, the type of affect that they're showing to particular situations and response to particular situations, and how they're actually interacting with people compared to other kids at their age. And there's several screening intervals that are available between 1 and 72 months. It does have specific things, and it's looking at externalizing and internalizing behaviors. So we think of externalizing behaviors being more of your behavior problems that you can see, your internalizing behaviors, things that are within, so things more like depression and anxiety. And it really allows for a nice opportunity to, and I would say that across all screening tools, it's kind of bridging the gap in communication between parents and professionals about a child's behavior. So it's really simple items. It's real simple to score. Just showing you an example of one of them. So when upset, can your child calm down within 15 minutes? So it's kind of getting at affect regulation, something that if you're working with someone that has a disability and you're trying to teach a new skill, and perhaps they have low frustration tolerance, having that information up front would be helpful for you in terms of how you proceed with your intervention. What's nice about it is that it gives us whether a child, based on the screenings, at no or low risk for something, whether they're more in that monitoring zone of maybe they might need additional evaluation, or if they're kind of in that refer range or above that clinical cutoff range. It also allows for parents to kind of remark on additional concerns that they might have from a qualitative perspective. Another thing, so this is a tool that is used for screening children between the ages of 16 to 30 months, which is the MCHAT. And the role of screening for autism, again, is, sometimes people begin to feel very uncomfortable in terms of, that's not really my expertise, that's not my domain, I'm not necessarily sure what to do with that, is remembering that we're talking about screening, not diagnosing. Screening positive on the MCHAT does not mean that a child has autism. We'll actually walk through some of those stats in a minute. Also, oftentimes when we're administering an MCHAT, that's being done in the context of other evaluation information you have or other developmental screening, and allows you to put it in the context of kind of the overall picture of a child, and provides that opportunity for further assessment and really helping to support acquisition of services when services are indicated. So there's an increasing prevalence of autism. Part of that may be because we're just getting better at diagnosing it. Early aggressive treatment is linked to better outcomes, so that's why we're really focusing on screening earlier. And this is 16 to 30 months. ASD can be identified before the age of 3 reliably, but the median diagnosis is happening after age 4. So if we know that early intervention is better, and we're not catching kids till after 4, and for families with that come from low socioeconomic statuses or minorities, they're being diagnosed even later than that. So, we're missing out on the potential benefits by not catching these children earlier. Within the context of the American Academy of Pediatrics, they should be screening at 18 to 24 months. I know for many providers that are funded by the trust that they also are beginning to engage in that screening. So it's a screening tool that's used to provide early detection. Things like the ASQ or maybe some of the other developmental screening measures are out there. They don't necessarily always screen for symptoms consistent with ASD. We want to make sure that we're not confusing, lack of eye contact, communication issues with something that might be perceived as shyness or something like that. And it really is trying to detect as many cases of ASD as possible. There is a high false positive rate, which, if you're the provider and you're talking about communicating results to the family, you have a high false positive rate if they screen positive but they don't actually have ASD. That is concerning. So it does have a built-in follow-up interview to actually reduce the number of false positives. So just for everyone's sake in terms of thinking about the MCHAT, is almost about 93% of the people that are screened with the MCHAT are going to screen negative. So it's only about 7% of the population that you screen. Now, within your setting, if you tend to work mostly with kids with disabilities, it's probably going to be a higher hit rate than 7% in your agency. So taking that in mind, I'm just talking overall. More than half of the people that screen positive initially, after you conduct a follow-up interview on the failed items, half of those children no longer screen positive. And the mean age of this is actually being conducted is at 26 months. Now, what's nice about adding that follow-up interview, and all of this is available online, it's open source, it's free. The ASQ SE, I forgot to mention, does have a low cost, but it's something that once you, it's between $200 and $300, but it is something that once you purchase the entire system, you can reproduce within your institution over and over again. So it's just a one-time cost. The MChat is free, and it's available online. With the follow-up interview, it's correctly identifying 98% of toddlers' developmental delay. So even if they don't have ASD, there's something else going on there for most of these kids that are failing the follow-up interview. And 54% of the toddlers identified as being at risk for ASD, even after the follow-up interview, were actually diagnosed with ASD. So that's important to remember, is that even if they're still failing the MChat after the follow-up interview, only about half of those kids are going to end up being diagnosed with ASD later on after a more formal evaluation. All right, moving on to kind of more broad-based screening measures. There's something called the Pediatric Symptom Checklist. This is more for ages 4 to 16. What I really like about this measure is you see a website up there. It is available online for free. You can actually fill it out online for free. It will spit out an automated report for you. The online version, I believe, is only available in English, but it is a nice feature in terms of having something that will give you a nice PDF, especially if you use electronic medical records. It's going to give you at-risk or not at-risk scores, and then it's going to give you some subscale scores in terms of externalizing versus internalizing behaviors. This is something that we would have the parents fill out. This one is available in Creole, which I think is important. For older kids, there's a use self-report form. For parents that maybe have reading difficulties, there is a pictorial version of it as well. So I like that. So it's kind of reaching as many different populations in terms of administration as possible. And we're getting kind of some specific domain scales that will give us an idea. So the ASQSE lets us know, hey, there's potentially a problem in social emotional development or behavior. What I like about the Pediatric Symptom Checklist is that it gives us more domain-specific information. So is it an attention problem, is it anxiety, depression, or is it a conduct problem? So it lets us know a little bit more information of where we need to be looking further. So as I said, it gives you a nice online report. It will tell you kind of what range the individual is on. It eases that sense of interpretation. It also makes it much easier for whoever is screening it to actually go ahead and score it up. It's going to reduce scoring errors, and that part is really nice. So even if you administer it in another language, you could go online and fill it out online and get this nice PDF report, and then you just have it for your records. The Strength and Difficulties Questionnaire, this is probably the most translated, most researched, open source, validated screening instrument for kids ages 2 to 17. What's nice about this one is that there's a parent report version, there's a teacher report version, and there's also a self-report version of it as well. It's available in English and Spanish. There's an online or paper administration. The online administration currently allows for there to be a free report that it spits out for you. That seems like that's going to be changing in the next couple months, where there might be a cost associated with it, but for right now it is free. And there's several different forms that are available on that site. Similar to the Pediatric Symptom Checklist, it also is providing us with information in particular domains. So overall stress, emotional distress, behavior difficulties, hyperactivity and attention difficulties, and difficulties getting along with other children. And it's also giving us kind of a social domain, so the extent that they engage in kind and helpful behavior with other people. And it gives you, in terms of the report, of kind of what qualitative range they're in. And then if you look at the specific scores up there, sorry, I'm not the laser pointer guy, it kind of gives you some percentiles to consider what that means, so that you can use that in terms of communicating it back to the parents, and it gives us some diagnostic predictions in terms of what we would be considering, especially where we're sending them for additional evaluation. So I think, and I think that this changes by the domain in terms of we're conducting this screening, but when we're thinking about interpreting screening results, and if we're thinking about trying to reduce false positives, and depending on the amount of time that you have to actually engage a parent in terms of screening results, is I think that sometimes when you take the time to look at some of those items of concern of like, okay, well, this could impact how I'm trying to interact with the child, is you said that Ronnie is throwing temper tantrums quite frequently, so like you go specifically to the screening item. Tell me more about that, right? Because that might give you some more domain-specific information about when that's happening. So if it's something where, it's only during difficult tasks for that child that they're throwing temper tantrums versus when a parent just says no, that gives you some information of when you can expect that, what you might need to do as a professional in terms of doing that. We also think about it, we talked about the perspective, there is a certain level of subjectivity that comes with this. When we have multiple people filling out screening reports, you may get, it's all about the same kid, but you get 3 very different screening results. I think that's important to consider. If the family has experienced recent stressful events or there's been a sudden change, that may be something of, oh, well, we had, they screened positive on this, but we just moved homes, 2 weeks ago, or the parents just separated, or maybe a family member died, or maybe there was exposure to witnessing some type of violence in the neighborhood. I think all of those things are things that are important to consider. Also just thinking about the parents' knowledge base about child development and child behavior. So like teen parents, if they have not had, additional education as it relates to that domain-specific knowledge, parents that are involved in child protective services, they may have a tendency to fake good. They want to be presenting like everything's okay. And also, if parents are engaged in substance abuse or parents with their own, psychopathology or their own behavioral health difficulties. So when we're talking about screening, is if you screen, you can't let this be just one more piece of information, is you always need to be providing feedback regardless of the results. Obviously, we want to be highlighting the child's strengths before communicating areas of concern. I think it's important to be honest with that and not minimize it. And really explaining that the next step is getting further evaluation to help out how maybe perhaps you can be most helpful to the child and for the parent can be the most helpful to the child as it relates to that. Depending on your situation, if you have the ability or you feel like you have the competence to provide, symptom relief, brief tips that will allow for symptom relief, I think that's always helpful to parents. And again, we've said this a million times, screening results are not diagnostic, and just reminding the family of that. And that this really should be a collaborative process of you engaging with the parents in that process versus, oh, you screened positive for attention problems. You should probably go get that checked out, right? That's not going to work out so well. All right, the other part is we need to move from, so how many of you get like pieces of paper from doctors? Like, here, go do this. Anybody? Okay. Or they give you a handout of like lifestyle changes you should be making, right? Where do those handouts go? You frame them, you put them up in your house. Maybe they might disappear into a wastebasket or a recycling bin pretty quickly. Sometimes, numbers get lost. So we want to be moving from just, here's where you need to go next versus a warm handoff of making sure that they actually getting connected. So explaining why the referral's happening, connecting the family with the indicated services. Maybe the most important thing you can do during your time with that family is make the phone call with them. We all know that, even us as professionals, navigating the healthcare system can be very difficult and complex, and we can get frustrated. And so I think that's another thing that could be helpful. If it's something where that service is available within the same institution, walking them to that place or making sure that they are truly connected to that next person. We know that if it's a within agency referral, the likelihood of follow through always goes up. And then once you've made that, make sure that it's actually happened. So having agency specific policies in terms of having a standard follow-up of what, has an appointment been made? Did you go to that appointment? Just make sure that connection happened. If you complete an exchange of information form with them, it will allow for better collaboration between you and the professionals working with the child. In terms of possible follow-up, for younger children up to 36 months, we'd be linking to early steps. 36 months up to 5 years of age fiddlers, and maybe to a school psychologist. It could be additional community agencies, parenting programs, behavioral health providers, parenting programs if a child has a diagnosis of ASD, making sure that they're registered with CARD, the Center for Autism and Related Disabilities. It may be referring them back to a primary health provider or referring for behavioral health evaluation. There's going to be times where you screen and you provide information for parents and you say, I think this would be the next best steps for your family. And they're like, I don't think that's the next best steps for my family, or I want to wait it out a little bit longer. I think that if you engage in the screening process and we're trying to link families to the next step, and maybe they're just not at a point where they have too much going on, they can't do that right away, is you want to document that that family is maybe not ready to follow up. One, so that it makes sure that it's a point of discussion for the future, but also to make sure that we have that in place in case things aren't going well in the future. Just document that we have made that attempt. All right, I finished on time. I sped up. That's why we have a timer. All right, so we have about 5 minutes for any questions for Dr. Hirschhorn and I. And if it's questions that you don't feel comfortable asking, you write them down, and we'll try and deal with them during the panel discussion. Yes? Yes. Yes, it's a one-pager that helps with printing costs too. Yes. Other questions? Cool. All right. Dr. Hirschhorn has to duck out, but like I said, I will be around for a good part of the day. So if you have screening-specific questions, I'd be more than glad to answer them. It is a big move. If it's something that you're not doing, to make the consideration to screen. We hope that we've presented at least a good rationale for why it would be important for you to consider. If it's something where you feel like where you're working that there may not be that opportunity for you to do that on a universal basis, I would say even if you can do it on a selective basis, I think that you'll get good return on that investment to screen. And I would say most places that even when they've started doing screening on a selective basis, if you keep that screening short and sweet and cheap, more times than not, those agencies end up adopting more of a universal approach to screening. I don't know if there's any last things you'd like to add.
Yeah, I'd make 2 points. One, pediatricians who have instituted screening have found it to be smooth and easy, and all the things they were worried about really were not issues. And I don't think it would be issues for you as well. The other thing I would mention is that there are billing codes for these screening tools. So you literally can bill for this and in some cases actually get paid. While we were all concerned, this is going to have a cost, are we going to get paid, et cetera, there are billing codes you can use.
I guess the last point I'd like to make, because I like to be nice and long-winded, is children's behavior is going to present in every circumstance and every situation, and we think that it's just important, and that's really the purpose of this conference, is to help you have more tools to feel like you are equipped to deal with those children's behaviors, or have, it's not just, hey, it's not that I'm just identifying this when I'm working with a child. You yourself as the parent, you completed the screening. Even when we talk via interview, you don't report it as a problem. But when I look at this, I look at your screening results, it sounds like compared to other children your child's age, that this may be an area of concern. All right, well, thank you so much for being awake right now. Appreciate it. Thanks.
Thank you, Dr. Hirschhorn and Dr. Jen. One point I'd like to bring up before I introduce our next speakers is that when we're talking, in the context of today's conference, we are talking about children with neurodevelopmental disabilities, but we define neurodevelopmental disabilities very broadly. So